you actually have seen me or are aware of who I am. My name is Madden. I am the Associate Director of Allied Health Professionals at the HHFT. I actually joined the trust last year in November, so I will be celebrating my first year anniversary here. Am I crazy with Julie? So if you want to tell her some good things about me today, please do. It's your time. And so anyway, before we actually start, can I just start off by saying thank you very much for every one of you at HHFT. We are not just talking about our registrant and unregistrant, but also our students as well, because every one of you are contributing towards our care, our work. So just a very sincere thanks. But just to say that these are a bit of our head count, roughly. But yeah, so thank you for all of you, your help. And I'm actually really delighted to see that we got a variety of colleagues actually joining us as well. We also have some colleagues that actually working with us very closely, like the St. Michael's Hospice colleagues we actually here as well. So that's fantastic. Thank you. So the theme, as actually Julie mentioned it already, this year is about quality and safety at the heart of care. And actually today, 14th of October, 14th is actually represent or reflect that we've got 14 different AHPs. Just to say, if you're taking a picture of me, please take it at a better angle before you actually post it, please. So just to actually say out loud, check it out before you post it. So this is about recognizing every AHP, your contribution, your work in not just actually at HHFT, but also in healthcare, health and social care as well. Now, as Julie already mentioned very briefly, this is like a fantastic time. This topic comes at a fantastic time because quality and safety are two sides of the same coin. You simply can't have one without the other. And at the core of the great care the core of great care is a commitment of creating a safe space for patients and staff and absolutely everyone who actually walk into work here. And actually everything we do, whether it's following safety procedures or working to improve patients' care, it shows how dedicated we are to making sure both quality and safety go hand in hand. So these are some of the strategies that we've got that is showing us what is going on in the trust as well. Some of you might have seen this already, and Julie actually mentioned as well, is actually we have launched the Safety Together campaign, and these are the three pillars that we actually got. We look into patient safety, staff safety, and environmental safety. And this campaign is really about transforming how we understand and approach safety. And it also recognized the pivotal role that we all play in fostering a culture of physical, psychological, and environmental safety. So to find out more, you can actually find it on TrustNet under corporate safety and governance. So that's actually quite a lot of information there already if you haven't had a chance to look at it yet. So I guess this is the thing. So some of you might be aware of this already. We launched the AHP's Deliver strategy in 2022. And this is actually the strategy for all AHPs. It doesn't matter whether, as I said, everyone as long as you're in the AHP community, this actually is applied to you. And it got a lifespan of 5 years, so it will be coming up to actually renewal soon. But I think this is actually aligned with what we're trying to achieve and what we're trying to do today about advancing, advocating, and achieving together as AHPs. And I guess, and this is actually, you will see some of our guests and actually throughout the presenters today as well, is as AHPs, our power really comes from working together and thinking creatively. So it's the innovations, it's actually the creativity. So I think by sharing ideas, and actually, as Julie mentioned earlier as well, it's really about how do we actually pick out a little bit that we think of that is actually going very well, so how can we actually steal the idea, pinch with pride, and actually make it better? Or is there something that you think that, oh, that is already happening, what about ours? Maybe that's something that we can also do in our team and in our professional group as well. So it's really about learning, because we are always on the dance floor. So this is a time for you to actually come off the dance floor, stand on the balcony to actually watch what's going on. So hopefully you will all have something to actually learn as well. Brilliant. So the next one, just to actually go through, is, and I think this is something that, again, Julie tapped onto it already, is that in the AHP Deliver strategy, there's two overarching principles. The first one is about co-production, so how we actually work with our patients, our carers, and actually all the relevant partners. But the second overarching principle, and I just want to give it a mention, is about committing to being anti-racist. And as actually we have heard already, is that the populations we're serving continue to change, it's becoming more diverse, so it's really about how we can actually think about our approach, how we can ensure that both patients and staff feel valued. And I guess one of the things that I also want to mention, right, and I learned it from actually one of our non-executive directors, Clancy Murphy. So Clancy actually said to me recently is that a culture is what you're willing to accept. And I think this is something that really speaks volumes. So I'm asking you today is that what are you willing to accept in relation to being anti-racist? So just to mention that. So I'll be very pleased to actually let you all know is that we are, as always, we're keen to support colleagues to be the best they want to be. And actually, some of you probably, if you're meeting me on a regular basis as well, is one of my ambitions is to support everyone to be an everyday leader, creating impact and influence within and naturally outside your circle networks. And we are very, very pleased that after a very competitive interview process, 3 of our amazing AHPs have been successful in securing a place at the CNO Fellowship. So I really look forward to hearing about their journey and how this program supports us as well. So well done. And when we're actually talking a little bit about how we, advance, advocate, and achieving, the first thing is we need to have a workforce. We need to have people to actually, in the workforce. So how or what sort of things we've been doing? I mean, first of all, I do have to say thank you because you all have been contributing in this. So a few sort of key initiatives anyway. The first one is actually placement facilitation. And you can actually see a very lovely picture here with our Trudy, with George, who is actually a physio student with us. And he actually received a WOW award when he was in placement with us as well. And just to say, since September last year, we have facilitated over 400 placements for AHPs. So just to actually say, it's a fantastic, if you actually think about the amount of people that we have got and we can manage this, it's absolutely amazing. And you can also see the top, that picture is a Duke of Edinburgh program. So obviously we are part of the CNO team, so we did a lot of work together. And actually, we are all about the MDT, how we actually improve patients' work. I think it's actually very successful because one participant on the day expressed interest to become an OT, one wanted to become a dietitian, and two wanted to become a radiographer, but they don't know whether it's DRAD as in diagnostic or therapeutic. So for us, that's still fantastic. We continue to do a lot of career and job fairs, and in fact, I think we actually, so far this year, we have done 8 so far. So really grateful, and thank you very much for all your contribution in this, because this is actually how we continue to stimulate conversation and get people to join us. Work experience, very, very briefly, just to say we have facilitated 39 days of work experience and shadowing. And these include local students, international individuals on spouse visas, so we actually got a lot of nursing colleagues, they actually came over here and their spouse are actually registered AHPs. So obviously we try to actually grab them come in as well. So we've done a lot of work experience, but also we have lots of support workers, AHPs and nursing colleagues actually expressing interest. So we are doing that during our working hours, so it's not an additional work and taking up time, but just to say this has been absolutely fantastic. So thank you very much for your effort and work. So just to actually say, building the next generation of AHP is very important, and we can't forget about supporting the incredible professionals already working as well. The needs of our population are constantly changing, and so are the demands of our workforce. So that's why it's very crucial for us to work very closely with our training providers, not only to equip future AHPs with the right skills, but we also want to ensure that our current workforce keeps growing and adapting. So what I probably want to say is that, for example, I'm absolutely delighted to see, I think Hillary here. Nice, so Hillary here, she is actually from Health Science University. So if you, and we also got colleagues from University of Winchester over there, so Sophie and Liam and a couple of colleagues there. So what I actually want to say, we did receive an apology from Southampton Uni as well, but just to say that if you have observed something and you actually think, hey, some of the students are fantastic, the courses they're doing is really good, or you think, oh, actually, is these included in their curriculum? Or if you've got interest in certain courses to actually develop yourself, I will encourage you to actually talk to our colleagues today. As I said, Health Science University and University of South Winchester. So please make the most of your connections and opportunities today. Now, just to actually say that we got the themes, we know about the train, retain and reform, and these are the opportunities we have. I always encourage people to think that where do you actually see opportunities in and out to help us grow? But my questions to you is, how do you play a role in seeking the opportunities to optimize your work and development? Because we do have a lot of things happening within the trust. So the first one I want to mention is the research opportunities. I don't know, Natasha, are you here today? So Natasha Chikabo will actually join us later. So she is our head of R&D, research and development. And I'm pretty sure that she will also be around for lunchtime. So if you've got any ideas or questions, please do reach out to her. And so that will be very good. We also have our people promise. I can't not mention our people promise, especially we are now having a lot of work happening with a focus on leadership as well. So I would just say Ashley, our Speak Up Guardian lead, and Steph, who is our people promise lead. Can you give us a wave so people know? So people should know about them, all right? But I will encourage you guys again to reach out and actually have a conversation as well. So thank you for that. And also, my question to you is, what about sharing our ideas for innovation, transformation, and improvement with relevant stakeholders? And today we're very, very lucky because we have got Philip Bailey, who is our AD, Associate Director of Business Change and Innovation. Philip. Oh, over there, so you can now recognize the face as well. So Philip over there will spend hopefully as much time as possible today, but I will encourage you to talk to him. If you've got any questions or any innovative ideas, then he will be your man. And I just want to say that the question that I would like you to actually think today is, are we making the most of what is available to us? And actually, do we know what is on offer? And actually, how can you go about finding these opportunities? So make a note of that. Is it working? Perfect. So I just want to show you, that's why you can see why I'm not allowed to take more selfies today. So, but for me, I believe that being visible and engaged across our services is key to making a strategic difference, okay? And I actually really gain loads of insights by talking to you guys, listening to your stories as well, so I'm also always very grateful. But every time you tell me your stories, I actually will translate and actually share with our partners. And this is actually how we can amplify your voice as well, so just to mention that. Key focus, I'm not going to actually say too much, but I think a couple of things just want to share with you, and I think this is something that actually Julie's been supporting me to actually think very differently as well, is that in 2016, we got the Safer Staffing Principles established by the National Quality Board. At that time, AHPs were involved, but the principles came out were not applicable to AHPs. However, the reasons the new National Quality Board commitment explicitly include AHPs. So the national team at the moment, they're actually working to arrive to the National Quality Board with effective staffing guidance for AHPs. And they actually will be submitting it, well, this is the first time ever really, though they will be submitting it by the end of the financial year. So I'm actually hoping that that will be something that actually will be very useful and help us to guide us. But if I can just mention a colleague, Mark Cooley, who is our therapy business manager at the family division. I just want to openly mention his name and say thank you, because while all these staffing guidelines and everything is happening, me and Mark, we've been exploring different options with different trusts, because obviously money is a bit of a, Steve is there, so I know he's actually keeping an eye on me. But what we're actually trying to do is, we know that some of the trusts, they actually have been having their own guidance, so we are trying to steal the ideas and actually make it better while using it for free. But I just want to say thank you very much for Mark, who's been helping me. And the other thing I just want to mention very quickly, as you can see, we've been using the QR code, and actually sharing with you our program today, because what we are fully committed in Green Plan, well, the Trust Green Plan, but also being greener AHPs. I'm very delighted to actually share with you that we have got our AHP Sustainability Working Group, And it's actually going very well. And thank you very much for colleagues who've been joining us and actually sharing with us. Miranda, if you can just give a quick wave here. So Miranda is from the sustainability team here today. And I know that Miranda is also going to encourage and reach out to some of you to encourage you to do a green plan survey.
Yeah.
With a bit of a token, apparently.
Yeah, you can win a £25 voucher.
So very exciting. But just to actually say that that is a fantastic way for you to have a say about how we actually deliver our service as well. And so I think I just want to actually say that this is actually what we are all doing to help. Very, very finally, before we actually move on, is just to say that I think for me, the reason why we actually do so much, and actually certainly for me taking all the selfie, meeting loads of people, is because from what you guys have been telling me, is that there's a need for us to actually raise AHP's profile and gain further exposure, not just actually within the trust, but also as part of the system. And I guess the focus is really about recruitment, retention, talent management, and actually how do we all work together, because today you'll be, well, some of you probably already noticed as well, is that it's not just AHP students, support workers and registrants, but you also have different colleagues, the OSM and people who actually make decisions. We want them to be actually part of seeing how they support us and how we do the work as well. So this is something that we're trying to do together. Of course, I'm going to finish my bit to actually show you the selfies I've been taking. This is only half of them, by the way. So just to say that the visibility of AHP is essential to growing our influence, because when our work is being recognized, it boosts our credibility with decision makers. Okay, so something that's very important when it comes to securing resources and improving recruitment and retention. And I think it's very important for us to actually share our stories, because all of us have a story to share. All of us are very proud of selected part of our work, and this is something that I actually will encourage you to think about, not just use the conference today, but also how do you continue to go forward to let other people listen to what we want to say. And actually, just a few questions to end is that what I'm actually asking you to reflect throughout the whole day is, with the work we're doing, have we won enough hearts and minds? And if not, how do we do this? And how do you bring attention to you, to your work, and your professional group? And we will definitely come back and visit these questions at the end of the day. So I hope you enjoy.
Well, good morning, everyone. My name is Carolyn Costa, and I'm here to share how AHP's put me back together again. So this was me prior to 2020. I'm a mum to two daughters. My husband, Will, was a university lecturer at the time. My eldest daughter, Eleanor, is a GP up in Sheffield, and my younger daughter, Hannah, works with domestic abuse victims. I was a keen dog walker with my husband, had a strong interest in Kenya, and did a lot of charity work, raising money by recycling jeans. I was a teacher at a middle school, and I loved reading. And then COVID hit. And we all remember those times, and I'm sure it brings back lots of horrible memories. The day that lockdown started was the day that I came down with COVID. And my symptoms were pretty severe, as they were for a lot of people at that time, because of course there were no vaccines to mitigate it. I struggled on for a fortnight, and then both my husband and I seemed to start getting better. However, what happened for me was that I developed a chest infection as a result. And of course, at the time, they were trying to keep people out of hospital. And unfortunately, as it turned out, that's what they did for me, because my chest infection had triggered pneumonia, and that triggered sepsis, which I'm sure you're all aware of, but please take time regularly to remind yourself, because what I've learned from my experience is how very hard it is for sepsis to be spotted. Now, I was correctly screened by paramedics, by GPs, but unfortunately I didn't have a strong enough combination of symptoms, and it was the time when COVID was actually complicating things. So after a week, I was feeling quite unwell. I was admitted to hospital, which was where the pneumonia and sepsis were diagnosed.
Sorry, Caroline. Sorry to interrupt.
Yeah.
Are you sharing the slides? Because we can only see the
Yes.
first one. Thank you.
I am sharing the slides.
No, we can see the slides, but are you still on the first one, the topic, or have you
No,
shown pictures?
I'm on the back and forth.
I can only see the first one. Oh, brilliant. Thank you. Now we can see it. Thank you.
Okay, but, okay. Let me know, I'll tell you when I change. When I came round from being in a coma for a month, my hands and feet had turned black. And I was told that they would have to be amputated. I'm changing slides now. Can you see that one?
We can see the black hands one.
No, you can't see the next slide. Okay, I don't really know what to do about that.
Yeah.
I'll have to do it like this. Can you see it that way?
Yeah, we can see the dietitian one now.
Okay, so this is where a lot of allied health professionals started coming in to play. And the first one I want to mention is my dietitian, Lauren. Lauren was a real mainstay through my time on the ward, which is where I was transferred to have the amputations. And of course, at the time I came up to the ward, I was still on a nasogastric tube, which I hated. And Lauren used to come and reassure me that it would get better. And when I started eating, then she would come at lunch times and make sure she came to feed me. Because of course, with my hands being black, I couldn't actually feed myself. And she was so encouraging to me that it made a huge difference. Then I had the involvement of speech and language therapists, and they came and made sure that I knew how to swallow properly, because of course I had to relearn all of that, and helped me to find out which foods I could tolerate at different stages. Also important were the occupational therapists, who fashioned a splint for me so that I could start doing things after my hands had been amputated. And this one was 2 days after my arms were my hands were amputated, able to work on the computer thanks to an occupational therapist who changed the splint so that it would hold a stylus. They also helped me to learn to transfer, and that was such an important skill and so good for my self-esteem. Using the splint, I was able to sign myself when I needed to have my arms revised. Unfortunately, the first amputation of my arms, which was done at my wrist, didn't heal well, so I had to have a second revision, and that took me to mid-forearm. And then I was able to start really recovering, I would say, and do silly things like getting the nurses to have a competition about who could face paint the best silly face onto my stumps. I remember I used to hold my stumps up every time someone came into the room, and they would just collapse into giggles, even the most serious of consultants. And then I went off to rehab and met with a new group of AHPs, prosthetists. One of the things I found most difficult, I think, in hospital was not understanding who everyone was. At certain points in my recovery, I had a constant stream of professionals coming in and out of my room. It used to sometimes actually be a queue. And it was really hard to know what everyone's role was. So I had to learn what a prosthetist does. And here I am being cast down at Queen Mary's Hospital in Roehampton for my first legs. I'm now 4 years on, I think my 8th pair of legs. Physios have been very involved in my early recovery at Bedford. I may have been their first ever patient that they had to say to do less, because I had the exercises all pinned up on my wall and would do them religiously to strengthen my leg muscles. And of course, all the sitting up exercises and everything. But when I went to rehab, the physios really got involved. And my physio, Kate, was absolutely fantastic. She really understood that I wanted a challenge and worked with me so that we set targets for what I would be able to do each week. And I gradually learned to stand with a pulpit frame, to walk with sticks, and then to walk without sticks. Well, that's me in the bars, and then to walk and stand without sticks, and even to master stairs, which is still a bit of my nemesis, but I was able to do them. The prosthetists and their technicians also made different arms for me. These were my earliest arms, and these are my wash arms. And this was a case of the technicians really working with me, because I had the idea to attach a head scrubber onto one of the arms so that I could actually wash my hair, and the technicians made that happen. And of course the OTs again were absolutely vital, not just in helping me to learn how to do things, but in the emotional support. This was taken when I first had my body-powered arms, and I've been really looking forward to getting them, but when I put them on, I cried, because I felt they made me look so disabled. And Jill, my OT, was absolutely fantastic in helping me to overcome that, helping me to understand that yes, there would be difficult times, because being a quadruple amputee is hard, but yes, there would be good times as well. And I gradually developed my use of my arms. I still don't wear them all the time, but with Jill's help, I was able to learn how to feed myself with them. And that was a massive step for me, not having to rely on someone else to feed me my meals. And when I came home, I was able to do some quite intricate tasks with them, including sewing. We also found, thanks to my daughter largely, different prosthetics. This is me eating in public for the first time with a koala arm, and they're absolutely fantastic soft prosthetics, which were only developed as I was recovering. I do have a bionic arm as well. It's probably the least useful of all the arms I have, and the one I use least of them. And this is me with all of my arms. I've got a growing collection. In fact, I may even have added one or two since then. Once I got home, with the help again of the OTs at Bown, we developed a bathroom so that I could use it, and I'm relatively independent in the bathroom now. I engaged with Remap, who are absolutely fantastic, and they helped me to develop other solutions, like adapting these toddler steps so that I can actually get onto the loo when I'm not wearing my legs. We had our kitchen remodeled so that I can actually do some things in it, not everything, but I can do some things, including I can do cooking in terms of preparing vegetables, thanks to this lovely chopping board, which was pointed out to me by Jill at Bown. And I found lots of other everyday tips and tricks that don't have the added disability tax on, which help me to do things around the home and get out and about and be more independent than actually I thought possible. And I've continued to invent some ideas as well, like these scissors on a mount, so that I could carry on cutting out denim. There are all sorts of everyday tools. I'm so lucky this happened to me now, which help me to be more independent. One of the main ones is the Echo Dot, which allows me to open and close curtains, turn lights on, listen to books, because reading a book is quite hard now, listen to the radio, listen to music, and connect with our doorbell as well. And here, another AHP came into into operation, because environmental control, which I had no idea was a thing, helped me by finding a stylus that allows me to use my computer more easily, and teaching me lots of voice control tips and tricks for both my phone and my computer. And I had the involvement of Wheelchair Services, of course, who assessed me for an electric wheelchair and provided a joystick ball so that I can actually control it. And now I like to say that thanks to all the help I've had, I'm living and loving my second life. I go down to London on my own and traverse the underground. I've been on Eurostar with my husband, but this is actually me waiting to be allowed off a train because the help didn't arrive. I've been horse riding, I've been up in a gyrocopter, I've spoken to one of my favourite authors and been featured in a book she wrote. I've been to Westminster Abbey for the now Prince and Princess of Wales's Christmas service. I was given an award by our local diocese for my teaching and charity work. I received an MBE, again for my teaching and charity work. I've been up in a hot air balloon. I've been a model for a line of clothing. I've been swimming, but decided I now prefer cycling. With swimming, I need a lot of help, and cycling, I can be a bit more independent. I've had a cat named after me at our local cat cafe. This is Utangi, named after the village in Kenya I used to support. I've had my portrait painted. The charity I work with in Kenya, we built this unit out in Utangi at the state school, and it's a unit for children with disabilities so that they can learn a trade, which is absolutely fantastic. I've stopped sewing but taken up weaving, and I absolutely love that as a creative expression. I've been out as a PEXA's therapy volunteer, although we've now had to retire Duke. I give talks. I've been on local radio and TV. I've had great fun meeting up with other amputees and contributing to research. At Christmas, I like to go a bit silly and have my lights on. And we've adopted a new dog, Daisy, who's in training to be my assistant's dog. With help, I go to the gym and exercise weekly there, which is fantastic. We've adapted our garden so that I have a raised bed, and this was how it looked in the spring. I planted every one of those bulbs. And I went on holiday to Kenya, not Kenya, it's far too cold to be Kenya, out to the fjords, and I managed to walk in the snow with my daughter, which is no mean feat for quadruple amputees. So I'd like to say thank you to all the AHPs who watch this, who help put people back together again, because I'm one of them, and though looking at me, you might think I'm really disabled. Actually, I'm really loving my second life. Thank you very much.
Caroline, thank you very much for an absolutely fantastic talk. And I just want to say a special thanks as well, because I think you probably cover most of our AHP colleagues here, so this is actually absolutely amazing. And I also just want to say this is the power of connection, because I actually found Caroline, I mean, I've been stalking her for a little while, and, isn't it, Caroline? And I'm actually stalking her on Instagram and Facebook and everywhere, you name it. And I reached out to Caroline and asked whether she'll be willing to actually give us the talk because of the amazing journey that she's been through. And the fact that I think what actually really drove me to you is when you mentioned about, it's about the MDT that you mentioned, the multidisciplinary, because doctors and nurses, they actually save your life. And I think AHP actually gave you a life. And I think this is actually really what is the theme about today, is actually we all contribute very differently. So Caroline, I just want to say thank you. And I love all your legs and your arms. So, I don't know whether you'll be able to hear, but I'm just wondering whether anyone would like to, if you have any comments or questions, and if you shout out, then I can actually say it to Caroline as well. Anyone got any? Just want to say we've got a few emotional colleagues in the crowd.
Oh, I'm sorry.
That's all right, it's absolutely Laura.
Just a comment, but just to say, Caroline, you are an absolute inspiration, and you make us all proud to be AHP. So thank you so much for sharing your journey.
Just to say that one of our colleagues here just saying that thank you so much. You've got a very absolutely inspirational journey, and you made us very proud to be AHPs. Thank you.
Thank you. I'm really pleased.
Any other comments? Anything? They're all on an emotional ride, Caroline. So just to actually say thank you so much for joining us today. I'm very grateful, and keep being awesome, and really keep sharing all your talk as well, because you are making massive change to our healthcare workforce, but also to actually other individuals out there actually who might be experiencing a lot of difficulties as well. So have a lovely day. Thank you very much, and take care. Bye. Our second keynote speaker today, and this is Bill. And actually, what we're going to do is we're going to do a bit of a question and answer session as well. But just to say that thank you very much for making such an effort to join us, come here today, and thank you for our ED ex-colleague here, because obviously, and actually Emily also. So I'm just wondering if you would like to just introduce yourself a little bit, and maybe if you don't mind just telling us a little bit about what led you to use the stroke support or join the hospital. That would be fantastic.
Sure, yeah. So good morning, everybody, and thanks for having me here. So my name's Bill, I'm 55, and I had a stroke in February this year, which left me in hospital. I was in hospital for 6 weeks, and then I was transferred to the ESD team, which I was very fortunate to be transferred to, as I understand it. So, talking about Caroline, I feel embarrassed to be here actually, because she had a much harder journey than I was starting. So, but that said, I've lost the use of my right arm and my right side actually, and my speech, but it's getting better every day. Thanks to a combined effort of some people in this some of the people in this room. So ESD was fundamental to that change. They saw me for 6 weeks. A very intense, program. So I would see people every day, and across all disciplines, so OT, speakies, and physios. So it was fantastic. I felt supported, and so yeah, it was very good. Thank you very much.
Thank you. So I actually met Bill because I was actually spending some time shadowing the early discharge support team, and I think on the day you actually had G with you. Oh, here we go, G, the star of the show. And so when I was visiting you, you actually did some physio exercise, and I think you just mentioned now is that you also had input from OT, occupational therapists, and also speech and language therapists as well.
Yeah, so that was all in person. So the really good thing was that they come to my house, and that was really hugely beneficial for me, because I was newly out of hospital. I didn't really know who I was. I didn't know my abilities at the time. So them coming to my house, one made me do the physio because I was scared of them, especially G. So it gave you that. You're in your own house, so you're comfortable. You feel secure. So it was very good, and they were very mindful of my fatigue as well, because they would only come in the mornings, and I need one after another, but they make sure they have at least an hour gap between their visits to allow me to cry in the corner, or recover, so I can speak to them. Because my first thing that goes is my speech when I'm either nervous, or as you can tell, or tired. So yeah, it was full on, and they all gave me programs, all gave me exercises that they wrote down. And they all planned a week in advance, which was really good for me, because you need to know what time to get up, because that obviously takes time now. So it was good, really good. But the whole, I got the full service.
Brilliant, thank you, Bill. And I guess just to actually say as well, and I think this would be a good opportunity to ask, what was the impact of stroke on you and your family, and what would you say were the key challenges?
Okay, how long have you got?
Wow, my friend, you've got 5 minutes for this part.
So I'm 55, as I said at the beginning. I've got an older family now, so I've got 3 daughters, 2 of which don't live at home. The youngest one I don't leave yet. I was a busy job. I worked for BMW UK. My wife runs a small business teaching children to cook, which is very rewarding for her. So I was busy. We were a very typical household, I suppose. I was very fit and healthy, of course. Did a lot of mountain biking, and I was part of a local charity that I've been involved with for 10 years, which is very close to my heart. So that was my life originally, and then in February it all changed, and the impact was very severe actually, on my wife particularly. I get emotional. So my life turned upside down, and as you can expect, if you can't walk or talk, then things do get quite difficult. When you're a doer, as I was, it can get quite frustrating as well, because you feel useless. That's probably my biggest takeaway is feeling useless. So, EST, and to be fair, the hospital were fantastic. I was very lucky to go to twice a ward, and some people again in this room, and then that sort of translates into the community, and they come out and see you. So they got me on the right track. They got me working, which I'm not scared of, and they helped me. I think you were maybe Caroline still putting that together, very literally for her, but not so much for me. And the other service that I want to mention is the psychologists, and that I didn't think I would need that. I was wrong. And so I thought from Nuna, and she's fantastic as well. I don't know how to help everybody else.
Thank you. I just want to say that I think everyone has their own journey, and you're absolutely right that like looking at Caroline's journey, you probably feel that like yours is not as much, but actually I think that is also your own struggle as well. So I wouldn't just say that like hers is a lot more. There's no competition here, Neil.
No, I'd like to lose.
On this perspective. But I think this is the thing, because you mentioned about you came into the ward, you were on private, and I think you were also, you were on private. And I think there's something about, and this is what NHS is now, is the fact that we want to get you home as soon as possible when you're ready, and it's more to make sure that you're comfortable, you actually feel confident in your own environment. But I guess the thing, well, why this service is so important, that you mentioned so much, is the fact that if you don't know what's going to happen, once you go back home, you actually feel like you're losing everything.
The transition to home is huge, and they all wanted me several times. I thought I knew better, clearly I didn't. And that transition is horrific. If you're not sure you can get upstairs, you're not sure you can get to the bathroom, you can't cook, you can't do anything, and you feel absolutely useless. So the transition to homes was horrible. So ESD really helped with that journey. They came in, they supported, it's not just coming in and doing physio, they come in, they talk to you as a human, they know what you're going to go through, they know before you do what you're going through, and they sort of set you off for that, which was hugely beneficial to me and for Joe, my wife. And actually our daughter, Darcy, was quite affected by this as well. And they then spoke to her, and she's very similar age to my daughter, so that's really good. And it's not just coming in and doing the physio, there's a bigger part to play in that. You're getting a professional to come into help, into your home, into your life, and that does have a massive impact. So it's a really valuable service, and I'm very lucky to have been part of it.
Thank you, Bill. So, you mentioned it already briefly, is how well did you think the staff, our therapy colleagues, communicate with you about your condition, your treatment options, and the next steps? Do you feel involved? Or
yeah, they were. They treated me as a human, and I would say that the humanity. Thank you. That I would say the other thing I'm going to say now, which is probably controversial, but that's me. The service is fantastic, what you've got here. The problem is it comes to an end. And that was probably very hard for me. So I'm not typical of a stroke demographic, I guess, although that is becoming the norm now. So normally you'd look at the stroke, as I would when I was on educators in this area, and you think of someone in their late 60s, 70s or 80s. Now most of those people don't work or don't have to, or they have the option to retire. So I know I'm being very broad with the example. But for me, I have to work. I've still got a mortgage. I've still got a daughter who needs support. My mother and father, my mum's just gone into a care home, so we've got all that going on. So for me, getting back to some form of usefulness that I can do is really, really important. The situation I'm in at the moment is, after the wonderful work that ESD has given me, and I can see what's possible, having that switched off is a problem, because now I'm not actually earning a salary because my company is sort of paying what they will. So I'm now having to fund my own recovery as and when I can. So luckily the charity that I work for has been very good. They've helped me some way, but that's going to have to stop soon. And I'm not at the end of my journey because I can't go back to work. So yeah, ESD is fantastic. It needs to be extended, is what I would say. But that's your job. if you want to pilot it for someone,
You know what? And I think this is actually why when I met you, I was very excited because I think you were very open. You actually share about your journey, and I think because, as you said, the demographic of our stroke, patients who actually experience stroke is very, very different. and I guess that's something that we're doing. And you actually tap into the next question I was going to ask you, is there anything that our service could do differently to help you even more? So you mentioned about the extension of it, and that's something, but obviously that's also is part of the funding, is the commissioning, and I think, me and Louise, we actually, Louise is our actually EBS lead, and we actually talk a little bit about how do we steer, and I think this is the reason why it's so important for us to share the story, and thank you once again, because unless actually the commissioners, unless the key people actually hear this, they don't necessarily, because, and this is probably my own learning as well, because they normally just focus on, right, we only got this product money, so how can we distribute it? And I think this is what sometimes we forget, that actually lying in the heart is actually our patient's care. There's a patient here that actually need the support, and it's really about how do we change that narrative. And so you're absolutely right, that is my job, and every one of you's job. So I think that's something about the visibility. I was actually going to ask you as well, is there anything that you would like to the other patients who might be going through a similar journey as you?
Yeah. So be determined, I think is probably the one thing. Never give up. And just never give up, I guess. You never know what's around the corner.
Here today, we also got a lot of some students, we got some support workers and apprentices that actually they are learning to become a registered AHP, but obviously some of us, they are happy with their roles. And is there anything that you can actually tell them, or like a wisdom, like share your wisdom?
So I think the NHS is fantastic, and I speak from the other side of it. You're working in the NHS, and I think the NHS gets a really bad press because it's an easy target. So I think that the majority of the people in the, I can't say that, the majority of people I know think it's a fantastic service, so thank you, all of you. And I think for a career, you won't see, I don't think, I work in walk work, which is very boring, and it's very fantastic. This is a real, the NHS is real life, real people, and that's what really matters. When it comes down to brass tacks, and the world doesn't go round in the corporate world, it's just about money, whereas this is all about people. And I think if you want to make a real difference in this world, this is the place to do it, because you affect all sorts of people all through life, and all go through their lives, and make a difference to people like me who wasn't expecting to use the service as much as I have now in my life. So yeah, so thank you all of you.
Anyone got any questions?
Sorry. Well, for you all and for the team as well, so without this team, what would your journey have looked like? Would it have been Twyford for months? Would it have been stuff in the hospital?
No,
I suppose, how did it?
We tried.
Yes, we did. So, I would imagine that sorry, someone's phoning me. I'll probably have to share it now. So I've been the physios that I've been allowed to see are the community physios. Now they're not neuro physios. If that makes sense. Is that right? And I'm afraid they don't have the training that would help me. In fact, they didn't know what to do with me. And in fact, they've not come back. So I saw them 4 times, possibly across all disciplines, and I've been signed off now. So I'm without ESD, that was what would have happened to me when I came out of hospital. And frankly, I wouldn't be here today. Well, I said I would be here today, but not in this form. So yeah, it's put me back together. Actually, it really has. And so thank you.
Any other questions or comments? Fine. Well, thank you very much, Bill. Thank you for.
So my name is Leland. I'm one of the occupational therapists working in the acute team in HHFT. And so I want to talk to you about a new pilot service that we've been doing, which is the therapy early discharge service. And today I'm going to talk about how we've been transforming patient flow and reducing readmissions and multi-discharges. So this work. Okay. So why do we need a TED service? So we want to reduce the number of failed discharges. We know as therapists that we see probably a huge amount of failed discharges within the first 24 to 48 hours of going home. And like Bill has actually said, it's that scary bit of leaving hospital and going home. That first 48 hours that before you've got the routines in place, before you've got structure, things do happen. And our team is there to try and make that safe as possible and reduce people coming back in. We want to enable positive risk taking. But we can, to reduce the length of stay, but that can only happen if we've got the right support structures in place. You know, positive risk taking is all very well, it's a great thing to do, but we need to have the backup of the community support there as well. We currently have quite limited inpatient resource from therapies. So we're trying to see patients on the ward. We would like to go out and do more things in patients' homes, but there isn't a service there. So we can identify patients that are being high risk for going home. We can refer to the community team, but there's not really anything with that. And our community partners, they work really hard, I'm sure some of them are here today, but they don't also have the resources to be able to pick up these high-risk discharges as quick as they would like. And equipment delays is another one that's coming more and more into focus at the moment. So our Hampshire equipment service, where we get most of our equipment that's essential for discharge, it can take about 2 weeks to get out to someone's home at the moment, which is when somebody's medically fit and ready, it's just the service doesn't really work. So we can really help out with that. We can go and collect equipment, take it home the same day, and reduce those delays. Best practice. So we know NHS England, NICE guidelines, protocol occupational therapy, but also talking about streamlining the processes, having the right care at the right time. embrace the risk, and also it fits with our trust in objectives, which we spoke about earlier, about outstanding care, working together, innovating, and using the best use of resources. And also we want to be in line with other trusts are doing. Again, what Vina said about learning from other people and other trusts and how they're doing, and actually how can we change our practice with that. So we know that other trusts already have a similar service to support patients with that first 24 to 48 hours of being at home. Some have intermediate care services, or hospital at home or at-home services. There's so many different variations out there that are helping to kind of bridge this gap between inpatient and community. So we're just a bit behind in that, and we'd like to get up to speed with that. Okay. So the aims of our TEDS pilot: to get patients home sooner and safer through therapy intervention is what we're trying to do. So reducing discharge delays and improving patient flow. So early identification of potential therapy delays. So if we know that someone needs equipment to discharge, can we plan it in and get a plan in place to get that equipment home, hopefully before they're medically fit and hopefully before it's a delay. If they're a particularly complex patient, what can we do to identify what problems there might be on discharge, and what can we do to get a plan in place to identify those. Encouraging positive risk taking and how we can get patients home sooner. Assessing patients in their own home. Again, like what Bill's just said about the importance of being in their own home, getting the right assessments at the right time. We have patients in hospital that actually, quite have some problems that actually the hospital environment is not the right place to assess them. And we know that patients do better in their own home from a rehab perspective as well. We might be able to assess them in their own home, and actually in a couple of days of practice with their wash and dressing or with their meal prep, actually they can be independent, they don't need that care element anymore. And we can also problem solve in the home environment. So it's all they were looking at a patient in a hospital bed and can they walk around that? Great. Actually, how do we identify that there's steps to their bathroom at home? Is there little bits of equipment that actually make a huge difference to that patient? There's a lot of value in that. Educating therapy staff and NDT on discharge options, and again about the positive risk taking. Preventing equipment delays, again like I said before, going, collecting that equipment, taking it out and being there for the same day for the patient. And reduce the need to wait for that just in case care for those patients that don't need to wait in hospital. We have a lot of patients, I imagine, we think, oh, I don't know if they need care or not, let's just refer for CRT. And then they have to wait possibly for a week for that. Actually, we can assess them at home at the right time, we reduce that need for that care and that delay of waiting in hospital for it. So reducing readmissions, so ensuring the equipment is compatible with the patient in the home environment. As occupational therapists, we order quite a lot of complex equipment, hoist, standing aids, and the standing aids we have in the hospital are the same as the ones in the community. You're not going to know whether it's going to work unless you've got the patient with that piece of equipment in that home environment and make sure it's safe, and that's what we can do. But even just being there on that visit, liaising with the carers, liaising with the family, there's so much individual in that. Force prevention, so look at somebody in the home environment, look at environmental factors, we can give education, rehab options at home, rehab programs, I should say, and there's a lot we can do there, and problem solving as well. So being reactive to any therapy-related issue presented within the first 48 hours of discharge. So not only this is stuff that we can identify before they go home, but if there's somebody that's missed our radar, actually they phone up and say, oh, actually, I'm in a bit of a pickle, we can be there, we can go sort them out and help with that as well. Care and family education is huge. Like Bill was saying, actually going home, and it's so daunting those first few days being at home, there's so many unknown, we can go and give that care and family education. And it also goes on to, I don't know if many people in this room heard about single-handed care, which is more of a new initiative that's coming in more and more. Patients going home with double-up care and actually can reduce that down to single-handed care. That's something else we can at. Problem solving and investigation of issues that arise. So we work quite closely with the Berkeley virtual ward. So when we get discharge patients, we can relieve them about the Berkeley virtual ward. That's the number they can phone if there's any other issues that arise. And and reducing deconditioning. So by going into the patient's home, explaining to the family, to the carers, to the patient actually how they can safely transfer and do things at home, reduces the risk of them maybe staying in bed for a little bit longer. And again, just gives them better prognosis on the term. Okay, moving on to increase independence and confidence. So that's not only the patient's independence and confidence, but also in the families and carers. It's a whole, like Bill was saying again, it's not just him that the illness or anything is affected, it's the whole family and the whole wider picture. And we can support that as well. So how do we work? So I should first probably by saying, actually, it's quite confusing how we bill an ESD service first. We're slightly separate, so we're working at the acute therapy team. I was lucky to be part of the ESD for a long time. I've worked with stroke patients, but actually coming in and working in the acute trust, there isn't the same service there. There's a big gap. But we're OT led, so it's myself at Basingstoke as a Bown 7 OT, and we've got a Bown 4 therapy practitioner. At Winchester there's a Bown 6 OT and a Bown 4 therapy practitioner, and at Andrew there's a Bown 4 therapy practitioner. So we're still quite a small team for this pilot service, and it's something we want to develop more. So we offer support to expedite discharge, and continue that support for up to 48 hours post-hospital discharge. So it's quite a small window what we can provide at the moment, but hopefully as we've got a bit more backing, we can hope to expand that and it can grow. But the reason we chose the 48-hour window is because we know that that's the time that patients really struggle. It's that first bit of going home. And that's also where community teams, they don't necessarily have the resources to pick them up in that time frame. So we're supported by the therapy virtual ward. So you said that earlier, but actually they're 7 days a week, 14 hours a day, and they can offer telephone advice, signposting, got a nurse on the team as well, so if there's any medical questions that we can't answer from therapy, they've got that as well. So it's just a little bit of an extra tool in our belt to help us along the way. Currently we're only really accepting referrals from acute therapists. That's because it's a pilot study, but we want to expand it further and see who else we can get on board with it. So a little bit about our data. So as a period from March to July, the TED service supported, it says 170 discharges, but actually the number was much greater, and we haven't included Andrea data in this presentation. We reduced length of stay, so 148 bed days, so that's quite a significant saving. We've improved patient care and confidence in 100% of patients we see. So from us going in there, the patients and carers have felt much happier, much more much confidence in their care and what to do with their relatives as well. Estimated to help prevent readmission in 94% of our patients. Reduce care by right-sizing care or equipment needs. Reduce preventable deconditioning. So just by getting patients up and out of bed and establishing those safe transfer methods, that can have a huge impact. And reduced our referrals to, our urgent referrals to community team by 64% as well. We still refer to them, but they're slightly less urgent. And we've got to just put a few classes on and hopefully make things a bit better along the way. So, looking at, I missed a bit, sorry. Additional benefits. So upskilling the staff, this is something we didn't really think about when we got the pilot up and going, but it's been a huge benefit. So by taking out junior members of staff with us, other occupational therapists or therapy assistants or physios, out on visits, they can actually see it in real life, and actually see the problem solving happening. They can look at the complex bits of equipment and complex discharge planning as well. It's been hugely beneficial. We've encouraged them to do positive risk taking. Some of the members of the team are a bit fearful of positive risk taking, others maybe a little bit not considering all the risks. So actually going through these discharge plans more thoroughly with our team has really helped. Everybody's come for reasoning. And alongside that, we've also, because the nature of TEDs, I have to dive into the notes a little bit more and find out after what's been happening to patients on the wards. We can look at that documentation and we can give feedback to the team that's involved with that patient. Like, have you thought about this or doing something differently? And that's really helped. Increased staff satisfaction. So when the therapy discharge went out for antibiotic, we had lots of applications for it, which is brilliant. I think it just showed that something exciting and new, and people want to do something slightly different, that's brilliant. The satisfaction I get from doing my job is huge. Being able to actually do that real OT in the patient's home and seeing the positive outcomes, like they were saying about having the ESD team in there for stroke. Amazing, so rewarding to do. And then that also helps with recruitment and retention of staff as well. We've had some great feedback so far. So we've had 2 RAL awards for our team, which we're proud of. Lots of the patients and family, they always say things like, it's so reassuring to know that we're not abandoned, it's more joined up service, where would I be without the service? All these kind of things have come back, which is brilliant. And again from the wider MDT about just having that joined up care and how reactive and flexible we are in picking these patients up. So loads of really good feedback that I couldn't include on the slides, it's too much. We've improved our links with community services, so our ICT teams and UCR, we're kind of trying to develop that a little bit further about what we can do. And ultimately, by having this extra team going out and doing the complex home visits and things, we are freeing up the ward therapist a little bit more to go and see the patients, make more timely discharge planning and help with reducing decondition on the ward as well. So, the future. So we'd like to continue our service. There's many benefits to the trust, which we've already spoken about, but also more importantly to the patient's well-being and their journey. We'd like to continue to follow up high-risk discharges, help avoid delays, and be responsive to crisis. We'd like to raise our profile a little bit more. We've had reduced staffing and a few staff issues. There will be the NHS about a few staff issues along the way. We've been very routine, very much knows about their service, but we'd like to raise that a little bit more to the wider MDT. We'd like to streamline our processes, our referral method, our assessment paperwork, our communication with the community teams and with the waiting staff. And we'd like to continue the education of positive risk takers. That's something that we've got a lot of benefit from and we want to continue educating our staff. Our current limitations, unfortunately, limited capacity. So myself and the other OT, we both only work 4 days a week, and there's no cover for when we've got annual leave or toil or sickness. So unfortunately, the service tends to grind to a bit of a halt when we're not in. It's a bit of a shame. And we're not a 7-day service. And unfortunately, we've had a few patients that might be referred on a Friday, and I've had a fall over the weekend. Unfortunately, we don't pick up pieces on Monday if they haven't already been admitted. So if we had a 7-day service, actually, what could we be doing within that time to reduce those readmissions? And currently we have a shared therapy car, which is brilliant to have a therapy car, but we have one therapy car between all the hospital therapists and also some AHPs, which means it's often booked out, and head service is very reactive, so I wouldn't necessarily know what I'm doing for the day until like an hour before, and then the car's booked. And for myself, having a parent with 2 children, I've got car seats in the back of my car, so sometimes it works, I can squeeze stuff in, sometimes I can't. So again, in the future, have our own car would be brilliant. So looking at future expansion, so with the increased resources, we're aiming to support a great number of patients. So we know that we've only just scratched the surface with this. We've had the ones that have been jumping out at us that to become, but we know if we ask a few more questions to all of our therapists and MDT, there'll be lots more patients that we can take on. There's loads out there that we can support. We'd like to increase our operating hours, so possibly starting with Monday to Friday continuous service and then moving up to 7-day working would be brilliant. We'd like to purchase a wheelchair accessible car. Things we could do with that would be amazing. We can get patients, we can take them home with us, we can get large bits of equipment in there, things that we can't do at the moment, and again, reducing the length of stay with that. We can start to explore short-term care options, so our therapy assistants going out and doing more practice with ADL, so washing and dressing or kitchen assessment, things like that, things that are important to the patient. A bit of practice with that, again, reducing the care needs. And also exploring how we can further help to reduce deconditioning. So linking up with the community teams about how that would work. We don't want to step on any toes, and also we want to make sure we're funding in the right place. But if we can provide exercise programs already, if we can do a little bit more rehab and look at the home environment before the community teams get involved, and that's only going to benefit the patient. But ultimately, we want to help bridge the gap between inpatient and community service and enable better outcomes for their patients and also better outcomes for the trust as well. And that's me. Thank you for your time. As we
Kathryn has just introduced, I'm Rebecca, an occupational therapist, and I'm based out of Cartwright Hospice in Andover. And
I'm Charlotte, I'm physio based over the road at St Michael's.
So as you know, there will be chance at the end if you have any questions, or if you're on the chat for separately in breaks, do find us being handed anywhere in the corner. Okay, so patient care demands a holistic approach which aligns perfectly with the core value skills of an occupational therapist. And our profession, as defined by the World Federation of OT, is focused on facilitating function, safety, autonomy, dignity and social participation through meaningful occupations. So for those that are OTs, we know that holistic is a fundamental approach to OTs, but actually holistic can relate to making sure that the patient is the centre of the treatment, but also having the likes of our other AHPs like the physios, and that can also include the patient's family and friends. So I just thought that was quite a nice way just to start the presentation. So just then going on to the AHP hospices. So actually we have two within our trust, but we do work closely with our lovely team in St Michael's Hospice. So I'm going to actually chat about mainly the ones in the trust, and Charlotte will go on a bit more about St Michael's. But to compare both through the hospice, we both have 10 patients, so they all have their own individual rooms with wet rooms. So that's good. So if somebody needs to be in a specialist chair, at least they can go in and you've got that dignity and you're not waiting for the bathroom that you might find when you actually are in acute. Both myself and Linda, who is an OT in Winchester, we both cross-site. So if one of us is on annual leave or sick, we can cover, and that can actually mean that I go off to Winchester. And that's really good because we are looking at that patient flow and reducing anyone having to stay in the admissions whilst they're in hospital. Whereas if they are wanting to go home to die and it's very short, we can support that to happen. Now, both us and St Michael's, we both have an outpatient group. So in Andover, we have the day centre, so that's run 3 days a week. And I actually input in that along with one of our therapy assistants and our senior sister. Whereas over in St Michael's, they've got the Live and Well group, and again, that will be touched on a bit further in the presentation by Charlotte. So mainly, I think that's similar again in St Michael's Hospice. We look at like the patient's individual's well-being, self-esteem, their social well-being, and reducing the carer's burden, because actually if they can come into the hospice for that day service, which runs for a good couple of hours, you're relieving that stress that that loved one may actually have while they're in with us. So it's really good, and actually I like it from my point of view, and I don't know, going with my colleagues, that actually when you're cross-covering, so I work in the inpatient community and the day centre, that you can look at what's going on. So actually if you've seen somebody at home and then they come into the hospice, you can see part of home, so you've already started that pathway. You go, yeah, I know this person's got to be at this level before they can go home, or vice versa, they've got that phase, you've seen them in the hospice, and then you can follow them up. So I quite like going, if you need my input, unless they're actually really sick, you've got me, so they know if they're ringing up somebody, they know who they've got, rather than asking, say, Southern Health to pick them up. So again, some people might have the perception that hospice is where people come to die, and actually they might have cancer. That isn't the case. Yes, people do come to die, but actually it can be for the bits that it is social, so they need to come in where you're looking for care. But it's also that symptom control, so actually if somebody is experiencing pain, they can come in, get on top of that. That again might highlight that they need a bit of therapy. Is it that actually if they come in for shortness of breath, do you need to look at equipment to conserve that energy? So you can look at those bits to ensuring that they are safe for that transition to go home. So again, one benefit we feel within our hospices is that you have all the MDT members that are important under one roof. So actually, again for me in Andover, if I need to link in with the community nurses, they're actually just based upstairs. So we can go and chat to them. If I've got a referral, I can say, look, this is this person, how urgent is it? Or we can say, I've had a phone call, what we do. So you're working on that better communication and that smooth, I'd say, patient transition to ensuring that they are safe. And actually, when you have got somebody there, is it that I can go out and then shout to the community nurses, actually it's just something for pain, or they go out and then flag something to me and you're not waiting half a day for an email to ping to you if they can't get to you. So this is the Cartwright Hospice, so this is where I work. So just a little bit about hospice. So it provides, we aim to provide an outstanding palliative and end-of-life care to adults suffering from life-limiting illnesses, and we cover people that live in Andover, Stockbridge and the surrounding villages. So actually we have got a vast area to cover, and bless our community nurses are busy covering all that, especially now they've lost a member of staff at the moment, whilst we're also trying to address the comfort and support to their loved one and carers. So looking back on the stats, obviously that has now increased, but I don't know that number offhand, but they did have about 1,000 individuals that we were caring for, based out in the community, but there's more within that. And we actually have a hospice charity fund, so that's helped with funding some equipment. And one of those that we can look at when you're looking at safety is the chair raiser. So actually if somebody's fallen, we can use that as an inpatient as long as we know they haven't sustained any injuries that prevent us using it. But we can actually take that home and see the individuals at home to reduce that length of stay on the floor, and then hopefully preventing that admission into hospital. So without the charitable funds, we wouldn't have been able to get those 2 chairs to support with that. Again, the community nurses, the palliative care team, they only had 2 nurses, but with the charity funds, we've been able to share for another nurse, so that's 3, to cover the vast amounts of areas that we're covering to help support those individuals. And again, if we need anything within our daycare service, we can look at getting those charitable funds to support with that development and during their time. So just a bit about myself. Within the cancer breakdown, it was a big step for me when I started to work there. So I worked up on Kingfisher Ward, and I've always had therapy around me. But compared to St Michael's, both me and Linda in Winchester Hospice, we're the only therapists within that service. So it is good because you're kind of your own boss, you can do what molds what you want. But you have got those limitations, especially when you feel you need a physio or another colleague just to touch base on. So before I started the council breakdown, they only had a therapy assistant. So I actually took on leading the development of that service, mainly in COB. And this is where, like any of us really, but we work autonomously, but I had to do that as a specialist OT. And I continue to create and develop the individuals' intervention tailored on their unique needs, again like most of us that we can do. And I do provide, as I touched on, the service within the hospice community and day service, so I do have to really look at how my day's planned. So like I said, we might start the day of this is my set plan, but then we have to look at service demands, we look at our priorities to adjust that whilst ensuring that with the hospice, where's their preferred place of death, so again that can change what your priority is for that day. I'm part of that, I kind of call myself because I could be a jack of all trades, because one minute I could be, I'm going to go and do walking and do stairs tests, and the next minute, because you are the MDT member, and I had to change that from not just a therapist, I might then have to go and help make a bed ready for admission or do something else. It's just chipping into what's needed for that patient's care at that point. So initially when I started, my job was only for a year. So through that period I looked at combining some stats. So just on average, month on month, I looked at, there was about 7 visits I'd done to support with prevention admission. I did about 60 triage phone calls. Visits I did about 15. I did about 12 to 15 admissions, that's seeing them in daycare. Okay, so I haven't even let Charlotte talk. So we've got cuddle beds, so we've actually got inbuilt fall sensors that helps with the safety of reducing the fall. So
I'm going to just whiz through. So I was at Michael's Hospice, it's across the road, it's fantastic. We have two lovely part-time OTs, therapist assistant and myself, physio. We offer all sorts of things across the inpatient unit, which again is 10 beds. We do bits of community as much as we can. We've recently started our Living Well service, which is amazing. It's kind of, the idea is that it's a day hospice, patients can come in for a few hours and then head away. So we've kind of got our educational groups. I've set up a breathlessness group, for example, where we look at various different symptoms across that. And we've got our non-educational sessions. So on a Friday, our lovely therapist assistant runs some really good groups across the morning and the afternoon, kind of that socialisation and almost escape from the disease. What I wanted to point out, if you don't have anything else from me, is that we've got this lovely new hand here that appears on EPR, it's one of the little symbols. If the patient has that hand, it means they're known to our service. So if you're thinking, you know, if you're an inpatient therapist, for example, and you see that, that's just what that means. And if they're known to us, we're really happy to help out. So if you want to know more about the patient at home, before admission, we're happy to help with that. Or looking for post-admission options, you know, obviously we're a very limited team, and we can't offer anything urgent, we just don't have the scopes. But if you think they're going to need some palliative input on discharge, we're more than happy to help with that. We also have a few clinics. So something that we are really passionate about is our neuro and MD input, sorry. So that's really good MDT working across all different specialties and some fantastic AHPs that you can see in our list just here. We've just set up our neuro clinics, so that's for general neuro conditions that have a terminal diagnosis, so like your CBDs, your PSPs, and we love that. That's quarterly. We have our MND clinic, which is monthly, and the idea is it's just like a one-stop shop for these patients where they can come in, you know, chat to a physio, chat to an OT, chat to a dietitian, chat to the neurologist, and it's just a fantastic coordinated service which we're really proud of. We can also provide assistance in applying for MNDA grants, so that's the Motor Neuron Disease Association. They are fabulous. And they offer various different pots of money for various different things, one of which is a quality of life grant, and that just allows access to different pieces of equipment. Obviously, we all know the struggles of pantry equipment services, so it just gives us a few little more options to really individualise the patients, so we can help with that. And we link with external agencies as well, so environmental controls have been previously mentioned, Poupart, orthotics, pantry equipment, and the one that I link us most closely with is NIV and cough services down in Southampton. So our patients who are on NIV, who are having cough assist set up at home. That's not something I do, but that's something they're amazing at. And where they don't really have that community input, we're almost their little kind of eyes on the ground, so we can kind of mention if things have changed. But I'm very aware we're very short time, so we'll skip the case study and just go to any questions.
So I'm Kathryn, I'm the MSK therapy team lead for the Basingstoke site. Just before I move on, I am going to throw my counterpart Mel onto the bus as well, who's sitting in the corner. So she's based at Winchester, but she's been instrumental in helping me to get this project off the ground, even just doing all the detective work. It's been a long, winded process, so I want to thank her very much. So we're going to talk about ED pathways. So the plan was to try and understand and streamline the referral pathway for patients who present to ED sites at Basingstoke and Winchester. So when they present with an MSK injury, they often need ongoing MSK physiotherapy to help them recover from their injury. But what we were starting to find out, just through questioning, physios are very good at asking lots and lots of questions, we found that the Winchester and Basingstoke pathways were, hopefully won't be much longer, very, very different. So we wanted to look and see if one was better than the other in terms of patient care, department efficiency and admin processes. So it was not thinking Basingstoke's better, Winchester's better. It was actually looking at the bigger picture and trying to work out what is more efficient. So, what we were hoping to achieve by this is, first of all, to improve the working relationships between our colleagues in ED and MSK Physio. we love to know everybody, and it's actually very useful to know lots of different people. So we hope that will be quite a good benefit, and has actually helped with other projects since, so definitely recommend it. We wanted to look at improving the patient pathways. We wanted to make it equal and more standard, so you should be able to present at Basingstoke and present at Winchester and then receive the same onward journey. We then thought actually we could start using this as a means to look at our digital resources. How can we be using our internet pages better? What are we actually giving to our patients? Linking again with what I've just written below, so getting patients to the correct location, receiving their treatment at the right place, which also links with our greener plan. I'm hoping that'll be around more, but there are links with that as well. And I can tell you a little bit more about that in a minute. But also then for us as managers who are always looking at utilisation and productivity is how can we then improve utilisation within our MSK physio clinics as well. I'm going to stress this probably more than once. This is an ongoing live project. It's turned into a proper QI project. We've asked lots of questions. I've opened cans of worms. I can't get the worms back in. There's lots and lots of them. It's leading on to more and more projects and more questions and things that we need to look at. So if you are going to look at asking questions, don't be scared. It will get messy, and that's okay. So this was our current process. So hot off the press, as of the 1st of November, we're actually moving to the Basingstoke process. I don't know how well you'll be able to see it, but essentially the main differences were if you go to Basingstoke, you're given self-management, and then if not improving, told to call the physio department after 2 weeks. At Winchester, it was called physio within 2 to 7 days. So there's a little bit of a difference there. We then found out through questioning that the admin processes were different. What we thought was happening wasn't actually happening. And you might have one member of admin staff that's doing it one way, somebody else was doing it another way. And so it was quite hard to get a streamlined process. And we also found that out of area patients, so your Newbury, your Andover, and Southampton patients were being seen initially at Winchester and then transferred to a local provider. Whereas at Basingstoke, we were just transferring the out-of-area patients direct to their local provider to start with. So, getting your feedback. So this was really, really valuable. Actually, we got to speak to a lot of different stakeholders. This is where the MDT approach came in. We spoke to physio teams on all 3 of our sites. So when I talk about 3 sites, our MSK service is Bolton and not Andover. We spoke to the ED matrons and their ENPs on Basingstoke and Winchester sites, engaged with admin. We utilised our therapy business manager as well, who really helped me put all the data because that is not everything. Our management team, we needed to get their buy-in, lots of positives that we could sell for that though, and then also linking with external physio providers. So as mentioned, Andover Physio doesn't sit within HHFT, so we had to engage with Southern Health. And just getting their feedback on how we can do it better. And then a further project will be to look at patient questionnaires. So we've only got the anecdotal evidence for that at the moment, so that's something that we can move on to. Barriers. We all like to think that as soon as you start changing things, it's going to be all rosy and all lovely and everybody's going to be on board. It doesn't work like that. So initially trying to get people engaged was really, really hard. There is unfortunately still a bit of a notion of, not really my problem, I don't need to get involved in that. But we know differently, it is everybody's problem. There is still that notion of, but we've always done it like this, why do we need to change? There were some perceived threats to some job roles. People thought I was going in looking at it, trying to take jobs away from them or make them do something they didn't want to do. And as always, time is a big one, actually having the time to do it. For me, it was the data analysis, and so numbers, not my thing, but Mel's very good with her numbers, and we've got Mark Pulley, our business manager, who also helped me to pull a lot of that. It's also kind of then looking at that reassurance and just trying to promote that QI culture within everything that we do. So, a few problems with the process as it was. So we were receiving different information. from patients, depending on which site they were on. So they might have come to Basingstoke but live in Winchester, so they might be given Basingstoke bit of paper, but then phone the Winchester department, all a bit messy. Travel and parking is always the big one. Physios were worried about missed injuries, incorrect diagnosis, patients trying to use the ED referral pathway to bypass GPs. That's quite a common one. They've got a number, and they answer the phone. Or utilising the pathway to get treatment for something completely unrelated. So we mentioned including empowering teams to be involved in QI and service improvement. It's something that all of our teams were doing. They were treating these patients. They were actually getting frustrated with some of the referrals, wanting to do better teaching. So it's getting people used to asking questions, can we do it better? We might not like the answers that we get, but actually it's really powerful to ask those questions. It's useful for us as a service, but also what is best for our patients. Greener NHS, stop people travelling further than they need to. Can we look at different resources, preventing how much paper we give out? And then looking at how we retain our staff. So actually if we can treat the right patients and get them better, they're going to be more motivated rather than treating them once, sending them somewhere else, you never actually get to see the benefit. And looking at training, improving, increasing training that we can offer. So, hot off the press, 1st of November this happens, so we're just going to stop seeing out of area patients, send to local providers, trialling the Basingstoke process of self-management for 2 weeks, and then call if needed. The standardised letter has been rolled out to the appropriate teams, so fingers crossed that works. And we can also then utilise the skills within the Winchester team to provide more training to ED staff to hopefully reduce the amount of missed injuries or incorrectly managed. And ongoing projects here, so looking at information we can provide, can we use QR codes more, can we use the trust internet pages more, do we get rid of the self-referral thing completely? I don't know, it's all questions. And likeliness, I love it. Social media tends to be more for my dog. I am that crazy dog mum. She does have her own Instagram account, but she did help me a lot with my process mapping. She did sit on it quite regularly while I was on the lounge floor. And actually I put this on my QR poster, and it drew people in to the poster. So once they came to have a look at the picture of the dog, I could then start engaging with them. And in fact, somebody last week on a course said, you did the project on ED, you remember your poster because it had a dog on it. So I can highly recommend it as a way to draw people in. And yeah, that's perfect.
Hi everyone, thanks for having us be here and inviting us today. I've got 2 more wonderful students with me, Cushy and Nick, who will be talking to you today as well. So yeah, as Venus mentioned, we are not part of the NHS, we're our friends across the road at the University of Winchester, and we've come to talk to you today about our innovative student-focused clinic. So we're based at the Bar End Leisure Centre, which is down at the bottom of Winchester, and Winchester University has grown its capacity for AHP courses, and then as a result of that, the pressure on placements has increased. So a couple of years ago, the university had the idea of this clinic, and one of the arms of that was to provide placements and also to serve the needs of the community within the private sector. So September 2021 was when we started, and we initially started, the initial arm of the clinic was to be physiotherapy students. And we've evolved that over a couple of years, and the plan is to build on that. So we had our first students in September 2021, and then we had a marketing student, so as well as the physio students, we've got students from other courses in the university that are contributing their skills to helping the clinic. And because of the nature of the university's placements, we've now looked at other university institutions to help give us some placements. So we work with Chichester University, and they provide us some students when we've got gaps in the University of Winchester students. And we've also been working with our nutrition and dietetics partners at the university to scope a project to build a nutrition and dietetics service. So that's very much in the process in the future, but the nutrition dietetic students came in the placement and they did some really good scoping work with our community, our existing service users. What provision would they like outside of what they currently get, or where do they feel there's a gap in the current provision? So we had some really good feedback from that. And I thought it would be important to tell you a little bit about our why, and I think this is really important to me and what the clinic's all about, because this drives our decisions. And I suppose we are quite unique in that we are a private clinic, but we work with a very specific ethos of putting students first. So what are we? I like to think we're a successful musculoskeletal private practice where the community is at the heart of what we do and what we offer. So we offer a range of classes and a typical outpatient appointment system. And at the heart of that is educating students. How we do that is we offer relatively affordable physiotherapy sessions with longer appointment times. This allows the students to not be in any pressure to deliver their care. And I think something that has become apparent to me is the clinical reasoning process that occurs in a standard physiotherapy session is often within the clinician's head, and that's never shared with the patient. But one thing that we've got some really good feedback from patients is what I ask of the students and what I encourage them is to articulate that clinical reasoning, and I'll challenge them on that clinical reasoning process so the patient hears that, and the patients often find that being involved in that clinical reasoning process is really, really important to their journey, because they understand why we're working towards a certain thing or why we've assessed something, which I think has been a really, really good part of the service that we offer. And then fundamentally at the centre of what we do is we wanted to build a reputation for providing high quality clinical care with a clear focus on supporting the development of students and within our local community. So, yes, we are a teaching clinic, and what does that look like? So we currently offer a 2-to-1 model of care, so that's 2 students, 1 clinician, which I think is a really attractive model of supervising students. 2 reasons, or a couple of reasons why, is it allows me to have a couple of students at once, which means I can get more help. It also allows me to give feedback to students, but I think really importantly it allows the students to peer-to-peer feedback, which I think is a really powerful tool to develop that communication skills within the students. Typically, I like to think that we've developed a supportive and reflective culture in what we do, why we do it, and how we do it. And at the heart of what we do is empower the students to make important decisions, and as you'll find out today, be involved in what we presented today. And one thing that I think is a strength of ours is because we're sort of facing the community, we tend to be quite agile to the community needs, and we found that quite quickly when the clinic opened that hydrotherapy was a big gap in the market, and was something that a number of our patients were in need of, and that has now become a big part of our service. So I will hand over to Kushi, who's going to tell you a little bit about that.
So as Leland said, Winchester Health Clinic does offer hydrotherapy classes, and they're suitable for patients who are independently mobile. So the typical patient would be, they'd experience balance or mobility issues, orthopedic conditions, or even persistent pain. And the classes help navigate these issues by improving their strength, balance and coordination, and through completing those exercises using proper use of water. So the buoyancy helps reduce the effects of gravity, which then eases the pressure on joints. And then the warm water also helps with their muscle relaxation, improving their range of motion. And the water also increases their proprioceptive input, so then that also helps their balance. So as well as these therapeutic benefits, there's also like a large community, as you can see through these pictures, where the patients who may have felt lonely or isolated can also experience benefits from being able to talk and interact with others through the friendly and supportive environment that we've created, and that makes exercise less overwhelming and engaging. So the classes are 3 times a week, and yeah.
And like Liam said, there's a lot of opportunities for us as students. We're grateful to be able to have somewhere so close to the university that we can go to and just really experience a mixture of community life and outpatient life, and just seeing a great range of patients. Yeah, a typical day for us involves preparing for patients, reading notes, seeing different pathologies that we may have never seen before, treatment planning, newly learned pathologies, and self-reflection time as well. So with Liam, every week we kind of reflect over what we've done in the week, how we can get better, things that we enjoyed as well. And it's good for us to improve in our journey as becoming a physio. Like I said, there's a ton of opportunities for us. Public speaking, which like this one now. And with Liam, I think as well, he has a lot of connections, so he kind of pushes us into different territories that we may not have been in before. So like the other day we were speaking at a class, a school, private school, and the other day we were in a training with some other neuro rehab patients and things like that. So yeah, and we also, like they said, the marketing. So we have a bit of marketing and advertising experience as well, how to sell physio, how to reach out to different clients and things like that, various workshops and things. But we're grateful to be here, and they create a very friendly environment for us. So far, I'll say my favorite placement. That's
£10 I'm giving you. And then finally, reflecting on the community that we're serving and some of the sort of gaps and opportunities that we've found, we're working with colleagues to develop both within the university from an academic and research perspective, and within some colleagues within Hampshire Hospital's pain service, is a community pain group, and with that is very much a peer-led, community-driven service to support people that are living with persistent pain. Of course, this will be something that our students will be involved with over the coming months. And also, we're developing a osteoporosis exercise class. Again, we've got a number of patients that we work with who suffer from this, and we're building an exercise provision that will be available to the community, that is aimed at building the strength of bones for individuals with osteopenia and osteoporosis. So that is an overshot of Winchester Health Clinic and our role within the community and what we do with students. So if anybody has any questions, we'd be happy to direct them to Nick and Chrissy.
For those of you that don't already know me, I'm Bown, lead interventional radiographer here at Basingstoke. And my stomach is telling me it's nearly lunchtime, so I promise to go fast. I just want to thank the Trust for giving me the opportunity today to share with you my recent experience of partaking in the Leadership and Mentoring Scheme which was delivered by the Society of Radiographers. So let's start with a little background. I graduated from the University of Hertfordshire and started my career at Hampshire Hospitals 10 years ago. I was fortunate to progress from a junior to a senior radiographer in the general radiography department. And then I took additional in-house training to subspecialise in interventional radiology and became deputy in that area in 2019 and ultimately took the lead role there 2 years ago. My personal beliefs are that self-advocacy, advancing your practice and acknowledging your achievements are essential contributors to maintaining your professional motivation, pride in your work, and encouraging a positive attitude towards learning and development. So this leads me nicely on to share with you why I thought applying for a year-long course alongside my clinical role was a good idea. So as my career has progressed, I have observed that the intense clinical demands within the NHS make it difficult for departments to prioritise, invest in and release staff to participate in non-clinical training. Often, individuals like myself transition from clinical roles into positions of leadership with very little support or formal training in that area. As an HCPC registered professional, we are required to meet our standards of practice for continued professional development. And due to the pressures I've just mentioned, I'm not shy to identify the opportunities myself. I was new to my managerial role, but I was aware that studies were being undertaken, highlighting that effective leadership and management can play a key role in fostering an environment where team members feel psychologically safe, in turn impacting on patient care and the development of your services. Therefore, one evening when I was sat scrolling on social media, I was a little bit interested when I came across a link for a leadership and mentoring scheme being delivered by the Society. I read about the scheme's intentions and reflected on the skill set that I had at the time, but it also made me consider what aspirations that I had for my personal leadership growth. I recognised that whilst I had vastly developed my knowledge and skills in operational and managerial aspects, thanks to the available resources within the Trust, I felt I lacked an in-depth understanding and the necessary tools that I wanted to provide my team with leadership at the level that I felt they deserved. So knowing that this was a unique opportunity, I approached my managers with a well-prepared plan, seeking their support for the necessary study time to enable me to apply for the scheme. Now, only 10 slots were available on the scheme, so when I received an email ring offering me a place, I was excited. I knew it was a valuable opportunity, hence I applied, but I was still apprehensive. Despite my aspirations for personal development, I'm sure like many of you here, change is challenging. I really enjoy my own comfort zone, and the prospect of stepping out of it and into the unknown was really intimidating. Before my first trip, there were many questions that crossed my mind. Was the course going to give me what I thought? How was I going to find the time that I needed? Were the goals I wanted to set appropriate? And my inhibitions also made me worry that I wasn't really good enough to have been given the opportunity. Now, as is often the case, my initial concerns were somewhat unfounded. Many of the individuals I met shared my concerns, but everyone was so supportive and eager to share in their experiences. Through a crazy radiographic speed dating sort of style game, we were paired with our mentors, and I was fortunate to be paired with Kerry Mills. Now, she's the programme lead for Cancer and Diagnostics, Workforce Training and Education at NHS England. And despite having the world's longest job title that I will never remember, from that first meeting I knew that we were going to form a great connection. We are both very passionate and driven individuals with surprisingly similar backgrounds. Our energy fed one another's enthusiasm and we achieved a lot, but in our excitement we inadvertently strayed away from our initial goals. I only realised it when I was reviewing job specs for roles that I didn't really have any desire to apply for, and I thought, I better tell her at our next one-to-one. I was nervous about how my honesty was going to be received, but testament to the respectful and strong connection we had developed, it was one of the most valuable conversations that we had. I had a light bulb moment. I realised that unintentionally I had kept the LMS as a very separate entity to my working life. Having never had the support of a mentor before, I hadn't understood that that individual isn't there to help you explore new things or groundbreaking ideas, but instead they are there so you can leverage their expertise to foster your personal development, shift your mindset, and better learn on the job to enhance your workplace effectiveness. So Kerry and I took a step back and explored some of the challenges I was facing at work, and with the new knowledge that we had, we set about realigning and adjusting our goals. So over the year, our mentoring relationship grew and we began discussing our personal lives. And it soon became clear that the connection between my personal and professional life is a lot stronger than I previously realised. Kerry was quick to identify that it's often my self-confidence and not my ability that holds me back. I have a very loud inner critic that often causes me to question and undervalue myself. If this resonates with anyone here, I strongly recommend thinking about the imposter phenomenon, because honestly, you're not going to be alone. Kerry has helped me to develop strategies to challenge my internal narrative, and although it's a challenging process, I am slowly learning to silence my own thoughts. So, I think the picture on the slide here summarises the journey I've trodden over the last year very accurately. The learning pit is a very real place. Challenging yourself to learn and developing yourself as an individual can be a really scary and intimidating As a mentor, Kerry didn't always give me the answers I wanted, but she provided me with a safe space where I could verbalise my thoughts, work through problems and feel supported. She often challenged me and prompted me to discover my own answers, and whilst at the time that was really tough, in hindsight I can see how much more I gained from it. So undertaking the leadership and mentoring scheme has taught me more about leading, mentoring and myself than I ever anticipated this time last year. However, I do have a couple of key takeaways that I would like to share. As an individual, I've always been hypercritical of myself. If I had to adapt or change a goal, I didn't like it. But I now understand that as insights are gained and circumstances change, it is natural for your goals to evolve. I recognise that these adaptations are necessary, and by embracing flexibility and creating space for innovation, we navigate challenges and allow for greater achievements. I've also been fortunate to recognise that there is a very fine line that lies between being a mentor and being a manager. I'm continuing to develop my knowledge and tools to allow me to trust in my own abilities as a leader. And in clinical practice, I've already implemented significant changes to how I manage my team, offering them mentoring opportunities to empower and enhance their own development. As a mentor, Kerry led by example. She demonstrated to me that self-investment isn't selfish. Working alongside a person so selfless, enthusiastic and genuinely invested in shaping someone else's future has ignited a passion in me to do the same for others. So my top tips for any other AHPs enjoying your day-to-day roles but wanting something just a little bit more. Remember you are worthy of self-investment. Take a moment occasionally to consider your career. Is there anything you wish to change, explore or discover? And don't be afraid or ashamed to ask. If you think it might help, seek out a mentor, someone who can help you, guide you, inspire you, and perhaps alter your mindset to think about things in ways you haven't done so before. And finally, don't let your comfort zone hold you hostage. Jump outside of it, take the risk. I promise if you seek out opportunities, you, your patients and your service will reap the rewards. So I hope by sharing my experience, some of you might feel empowered to identify opportunities and advance in your own practice. As I've learned, sometimes taking that initial leap of faith isn't as scary as it first seems, and you never know when it may be one of the most impactful and valuable experiences for both your personal and professional development.
Hi everyone, so my name's Andrea Brimson. I'm one of the MSK physios based at Basingstoke Hospital. So today I'm going to talk about my research that I recently did on outcome measures, how I implemented the outcome measure, and where we are now with the data from the outcome measure. But I hope the word outcome measure doesn't make you all want to go into a post-lunch coma. I hope I'll make it slightly interesting for you all. So about 18 months ago now, I was lucky enough to gain some funding from NIHR Wessex to look into a research project of my choice. It was really invaluable. It gave me a day a week for 6 months to come out of the clinical setting and just dedicate my time into looking at research. And I chose outcome measures because, while information on utilisation and waiting lists and DNAs is really important, so is the quality of the care that we provide to our patients, and we can prove the quality of the care that we provide through outcome measures. So the title of my project was to investigate the most efficacious patient-reported outcome measure, and then digital use of this within MSK, so it's a scoping review. So I have 3 different objectives in this. When you start looking into outcome measures, it's a massive, massive amount of information out there. So I had to really kind of define what I wanted to do. I used the term efficacious because I wanted the outcome measure to be valid, reliable, time efficient, holistic, covering lots of different areas for the patient, not just pain, function. We needed to cover how their conditions affected their whole life. What are others doing locally and nationwide? What outcome measure are they using and how are they implementing it? And now we have gone digital with our note taking. We need an outcome measure that is also digital. But what are the barriers and opportunities to using an electronic outcome measure? So there were 2 phases to the project. Phase 1 has split it into the actual literature review of the outcome measure. Staff stakeholder groups, this is key for me. Staff who are going to be using this outcome measure day in, day out, and need to know what they want, what they need, what they think is going to work for them to help with the compliance of using this outcome measure. An audit of the current outcome measures, the audit of the previous outcome measure that we were using was the PSFS, Patient-Specific Functional Scale. An audit of that showed that 16% of us are using it on the initial assessment, only 1% were using it on discharge. It wasn't working for us, and why was that? So I needed to look into that. I had to have close communication continually with the IT and business intelligence teams to make sure that my ideas were going to be feasible and that we were going to be able to use what we wanted to use electronically. So from the literature review, the best outcome measure, so the most efficacious outcome measure really through months and months of training through the research was the MSK-HQ. So it's an outcome measure that has 14 domains on it. It doesn't just look at pain and function, it looks at sleep, well-being, fatigue, self-efficacy. It's a score, you end up getting a score out of 56. The higher the score, the better their MSK health status. And an increase of 5.5 on the scale is a significant improvement. And it's a patient-reported outcome measure. So it's a true reflection of how the patient feels that they've progressed, not the therapist just doing the score and thinking how they think they've progressed. It's a true reflection of how the patient feels they've progressed. It's valid for all MSK conditions, so inflammatory conditions, persistent pain conditions, which is a lot of what we see in MSK. The results from the staff focus groups, these are my key stakeholders. Some of the comments that they made were, it needs to be function-based rather than just focusing on pain alone. We want one measure. Previously, sometimes we've been using different measures for different conditions, but one measure for everything. Let's just make it simple. It needs to be meaningful and goal-specific for the patient, otherwise they just won't complete it. The main barrier to using outcome measures is time. Like staff, they know how important it is, but I'm just too busy. I don't have time to complete them. The data collected, it needs to be used. There's no point in us collecting all this data if it's not going to be used and it's not going to be fed back to staff. So I took all those comments on board when I was thinking of how we're going to implement it. Phase 2 then was looking at the barriers and opportunities to using the outcome measures electronically. Once I'd found the outcome measure, I then kind of sampled with a few patients some interviews about what they thought of it. Do they think did they think that they would complete it? Did it look user friendly? And how they felt that it would show